Hello, everyone. Buzu, Kate Indigenous, Biktagan Anishinaabe and Doji. Good afternoon, everyone. Welcome back to today's Women's Health Talk with Dr. Alexa. Today we are gathered to learn about a very important topic, gender affirming care. And to lead us in this knowledge, we have our educated, kind, and Anishinaabe doctor, Dr. Alexa Lesprance.
Sweetheart, oh my God.
So, miigwech for being here, Alexa. And before we begin, and in order to start things off in a good way, I'm going to start with a smudge. So I'm just asking the creator to send this sacred smudge to everybody that's tuning in today in all four directions. And I'm asking the creator to open our hearts and our minds and our souls to really be able to learn about this topic that Dr. Alexa will be presenting on today. And I'm also asking the creator for the people that this topic pertains to, and for people that are a part of the 2S LGBTQ plus community, that they are offered some gentleness on their life journey, and that we can really take these lessons so that we can better care for our communities and their families. Right now we're going into the 8th grandmother moon, which is honoring the thimbleberry. And so this moon really reflects on the teachings that we receive from the spirit world. So I'm asking the creator that this teaching today can really resonate with us and help us to better service our community. I'll light it a little more and then you can speak. Oh, okay. So just a couple of housekeeping items. For those of you that are joining us for the first time, and just a reminder for those of you who have joined us before, just to be able to create a safe learning environment, you will not be able to turn on your mics, and you will not be able to see each other via your cameras. If you do turn your camera on, Dr. Alexa will be able to see you, but you just won't be able to see each other. If you have any questions or comments, you can type them in the chat, and then our moderators will pass these along to Dr. Alexa, and she'll try to answer all your questions. About the midway point, we will have about a 10-minute break. So if you need to grab any sort of beverage or stretch your legs, we can do it at that time. And also, per usual, we will give you guys a survey link at the end of our talk today. And for those people that do complete a survey, you will be entered into a draw for a prize. And we really appreciate everybody that fills out the surveys. It really helps us be able to guide these talks and know what we're doing good and what we could do better on. So finally, I want to say again, Chimigwech to Dr. Alexa for leading us in our learning journey today. Um, like I said previously, today we're going to be learning about gender affirming care and what that looks like. So if you're ready to begin, I'll pass the mic to you.
Great. Awesome. Okay. Thanks everyone for coming. So yeah, as Kate was mentioning, this is super interactive. I'm literally just here to answer your questions. This is information that I think is relevant and cool to you, but it might not be. So if you have questions, we do keep on top of them and I do try and answer them live. So if you have any, please let me know. Okay. So first introduction, so Ani Buju, Sabe Kwe, Indigenous Cause, Nakwando Dam, Noktumingwaning Donji, Bijano Abeg, Zaging, Anishinaabe and Donji, Makwando Dam, Anishinaabe Kwe and Dao. So my name is Alexa. I am a family doctor in my third year of practice. I'm originally from Rocky Bay First Nation, which is in the Robinson Superior Treaty area. Midway through our life, my mom switched our bands and we lived in Whitefish Bay First Nation, which is in the Treaty 3 communities. I am from the Bear Clan, and I think a big part of being from the Bear Clan informs why I took interest in medicine, given that Bear Clan people are often healers in the community. So that's sort of, I think, where I get a lot of my direction from. My pronouns are she, her, and yeah, I wanted to share a bit about myself. For people who've been to these talks before, I always start the conversation with, like, why should you listen to me or why should you trust me? And I kind of joke because I don't trust doctors. So how am I gonna expect you to trust me? So I want to share information about myself so that you get a sense of who I am. And so then you can interpret what I'm saying to you from that lens. So in the left-hand corner, I have a picture. So this is actually, the PRIDOC, the Pacific Regional Indigenous Doctors Congress. So this is where all of the Native doctors in Turtle Island, Canada, the US, Hawaii, Aotearoa, which is New Zealand, Australia, and Taiwan. So all of the Native doctors in the world that are on the Pacific, I should say, come together every 2 years. And so that was a picture from that. In the middle, this is, you can't really tell what I'm doing, but I am casting an arm. I have a picture of my graduation with Elder Roberta and my co-resident, Kelly. So I graduated from Nawsum Medical School, but I did my family medicine practice in Vancouver. So I worked mostly in the downtown east side. I was in the Indigenous Family Medicine program, so was just so blessed to learn from other Indigenous preceptors because there actually aren't a lot of Native people in medicine, as you probably recognize and see. So being able to be trained by other Native doctors was so rewarding and also just kept me from fully burning out of medicine because that happens often. The bottom left-hand corner, so that's a picture of my grandparents and my Nesimis, my sister. We're just building our family sweat lodge that gets done every spring and fall. In the bottom right-hand corner is me harvesting bark. So I'm Western trained. I grew up with a lot of medicine people in my family. So grew up around a lot of ceremony and traditional medicines. I actually wanted to be a traditional medicine person as a job. When I was little, like 5, I was like, this is what I want to do. Then kind of realized I didn't really have the spiritual gifts. I'm not fluent in the language. And so the next best thing I could do is becoming a doctor. So that's the esteem in which I hold our traditional medicine people, is that's what I wanted to do, but I actually, given my gifts and my knowledge, wasn't able to, because that is how much is needed to fill that role. So I just have a lot of admiration. I myself in my practice know a lot about traditional medicines, but in terms of prescribing, I'm trying to figure how that works. There's kind of basic things that I can recommend, like raspberry leaf tea for menstrual or pregnancy related issues or menopause, stuff like that. But otherwise, I'm not, so skilled that you could sit with me during a visit and we could talk about, testosterone, and I could give you the traditional medicine equivalent. I don't have that knowledge yet, but I hope I can get there one day. So this is an image, a meme that was created by my really dear friend Fallon, who's a two-spirit artist, and just amazing human in general. And it was just so this is a photo, a self photo of them, and it says, "My pronouns are they, them." And so they created this image in response to healthcare appointments that were really difficult, where people weren't even really acknowledging someone's basic human rights, which is to address them by their proper pronouns. So I have the right to access service providers who use my pronouns accurately 100% of the time. And if that's not what we're able to do, that's what we're aiming and striving to do. And providers and healthcare really aren't perfect in this, but that is your right to still demand and expect quality of care that includes something really basic that's a human right. Um, I know that around this topic, it can definitely be really challenging, especially for our community members, to advocate for yourself in healthcare just across the board. When you're adding in gender, sexuality, transition, hormones, like that can make it even more overwhelming, especially if you're feeling sick or afraid. You're anticipating how you're going to be treated. You're scared that the provider might not treat you well, or that they're not going to know what you're talking about. So it can be really challenging to speak up and say what you want and what you need and what you expect. So I just give this caveat to let you know to do your best to speak up, because you have rights, you have patient rights. And so you are deserving and should be taking up space in clinical encounters because you are the expert in your own body. And healthcare providers should be there to facilitate that, to help get you to where you want to be. Um, so so at the Ontario Native Women's Association, so we do quite a few different things. So one, we have our Gender Journeys program, which we can post a link in the chat, but that's essentially for youth age 18 to 29 who would like more support and more in-depth knowledge around this. It's like, I think, an 8-week series or something like that. And we just try and support and offer cultural teachings in addition to information about LGBTQ health. We also have a new workbook that's on our website. What's it? Do you know what I'm talking about? The toolkit that we have? Oh, Love Builds the Bundle. Yes. Okay. Thank you, CJ. So Love Builds the Bundle, which we can also post. So just supports that we have available. But we want you to feel like your authentic selves. And so this may include hormone therapy, surgeries, ID changes, name changes, or it might not include any of these things at all. It's all your journey. So really my job today is to provide as much medical information as I can so that you can make informed decisions. I myself am not an expert. And this is also not something that I personally have had to go through in terms of my health journey. So the only perspective that I can really offer is someone who regularly helps trans people transition. So the first thing that we're going to go over, just so that you have this awareness of like what the process entails. So changing your sex designation on birth certificates. So when you want to change your sex designation or your name on any piece of identification, the easiest, not even really the easiest, the best way to do it is to first change everything on your birth certificate, right? Because that's where you get your like the health card, your health card is derived from, that's where your license is derived from. So that's like the best place to start because it verifies, your birth certificate verifies all other IDs. So when you're changing your sex designation on birth certificates, unfortunately, there's not really a lot of options, which is unfortunate, but you have the potential on the form to change it to F, female, M, male, or X non-binary. And unfortunately, those are the only sort of options that are available. And they say on the form, that's for the province of Ontario. So like say you were to move to Saskatchewan or Manitoba or a place where they might have different designations available. Technically, province to province, this might not be recognized, which is also something that's really unfortunate, needs to change about this process. But essentially, yeah, first step is this lovely only 2-page form versus the other form, which is 17. But this is the application for changing the designation on your birth certificate. There's different aspects to it. One is a statutory declaration. So that's essentially where you need your original birth certificate in order to apply for this change. If you don't, then you have to then do another form and pay a different fee to get your original birth certificate. But usually this requires a notary public or a lawyer to sign off. And it does also require a letter from a healthcare provider. So it can be a doctor or it can be a psychologist, depending on what you have access to. Like I said, the actual birth certificate. And if you don't, here's the other form, the request for your birth certificate, and whether you need the short or your long. Ideally, it's best to have your long birth certificate, because that's a better verifier for other pieces of identification. So the process overall, I guess, depending on if you're going through programs that can maybe help subsidize these things, which there are some, I don't know off the top of my head, but that would be available if you were to Google that. It's probably about $75 to $100, assuming that you didn't have your original birth certificate. Okay, so that was changing your sex designation. Changing your name on a birth certificate is definitely a lot longer of a process, and just has a lot of, like, the application is 17 pages. So for people who have done that, you probably know how onerous this form was, but essentially, so it just requires, your mailing address, how many years you lived in Ontario, what you want your name to be. There's unfortunately this part of the form where if you have been married and you have someone else's last name, you have to give that person 30 days notice, which is messed up. But anyways, I don't know. I don't know how they're keeping track of who's getting their 30-day notice. But technically, if you have a name that legally has been changed through marriage, you have to give that person notice. You usually need your parents' information. If there's a criminal offense history, and if so, then you would need to go to get a police record check, and that's something that's you have to usually go to the police station in order to request this. Also needs a guarantor, which doesn't actually have to be a lawyer. Like, for example, it can be a physician, a chief justice of the peace, or a provincial judge. But all of these forms can be found here. So the Central Forms Repository. So if you just Google the Government of Ontario website, or you look of the Central Forms Repository, this has pretty much every form that you would need whenever you're applying for something for the, like, from the province. So that's the process for it. So it can be costly, it can be onerous. There are programs that can sometimes help subsidize. Would definitely encourage people to try and find those resources. Otherwise, it is there are quite a few steps involved, but it is possible. And I think for a lot of people, it does make a difference in how they see themselves and also how they're perceived. One thing to note, though, even if you do change your sex designation or your name on your birth certificate, the deep repository, because the government of Canada has archives, right? Like archives of, like, deep repositories. So the ones that are kind of, like, deep, I guess, aren't the ones that are changed. It's just the public facing form, right? So, like, when I give my birth certificate, it's gonna say that. But if someone were to really dig about, like, okay, what was the birth record, like, the records that are kept for everyone in the province and in the country, then that unfortunately is not changed, just the public facing document. So the first thing that we're going to talk about is feminizing hormone therapy. So the goal of feminizing hormone therapy is to, one, reduce testosterone, and to increase your estrogen. So people can want to increase their estrogen and have, like, with or without the intent to change secondary sex characteristics. Secondary sex characteristics is stuff like your body fat distribution, your hair, like the size of different body parts. So usually when people are starting something like, in this case, estrogen or anti-androgen blockers, there's usually they usually want some of these changes. That's the anticipated and wanted change, but it might not be. So the first thing I'll talk about, because it's the first sort of thing that people have access to. So something to note that people don't necessarily realize is that um, a lot of people have a sense of their gender as early as the age of 2. So, you know, where people say, like, oh, I don't want them to play with certain toys because then they're going to blah, blah, blah. It's actually not accurate. Children actually usually are not socialized into their gender. They usually have a sense of that as early as age 2. So, when someone is going through puberty, which in Anishinaabe culture, right, that's a rite of passage, and it's a part of our life stages, where you're no longer a child and you're slowly transitioning into becoming adult. So the process of puberty, which is your body changing, can be stopped, and that's using these anti-androgen um, agents. So spironolactone is a really common one, and Andicur. So these are both tabs that people can take. They're also, when people colloquially refer to puberty blockers, this is what they're talking about. And so the goal of it is that, so someone enters puberty for, like, I don't know, a little bit of time, because you wouldn't really start puberty blockers before puberty is started, because you have a small amount of hormones to begin with. So we don't want to lower an already small amount of hormones. So there just usually needs to be a process. The average age of puberty, I mean, it's becoming younger and younger in terms of like getting your menstrual cycle and things like that. But usually 8 to 14 years of age is when people go through puberty. And so the goal of taking a medication like this is either to prevent or delay puberty until someone, I guess, is older, in which case they could start hormone therapy. So it's kind of the first thing that you would take if you were like, you know what, I have a sense of who I am, testosterone. I don't want the effects of testosterone, the puberty effects of testosterone on my body. And so I would like to take one of these medications. And essentially, it gives you time. One, time so that you're not getting changes to your body that are irreversible. So, for example, if you were to like start developing like an Adam's apple or something, that's an irreversible change that puberty can cause. That would be hard to, I mean, people get like their tracheal shaves or Adam's apple shaves, but there's just certain things where it's like we don't really want that process to, if you are in the situation, you don't want that process to start. So you would start this early so you had time to think. Maybe, I don't know, you're 16 and you're like, actually, oh, this is fine. I don't need to block puberty. I'm just going to continue like with this specific set of hormones. I'm not going to take medication. I'm not going to do feminizing hormone therapy. Then that's fine. You have the potential to stop. But the point is that you have the option and the freedom and just the time to be able to think like, hey, who am I? The effects of puberty blockers, once you stop taking a puberty blocker, that's it. It's fully reversible. So it's not like you're not doing something irreversible to your body when you take either of these medications. And it's just so that you can have time to actually explore your identity and figure out what's good for you. So the way both of these medications work, though kind of in different capacities, is they're just blocking androgen. Androgen is testosterone. It's blocking testosterone. So both of these medications are covered by the Ontario Drug Benefit, and they are also covered by non-insured health benefits. So you're taking this medication because you want to start or like stop the process of getting your body naturally changing and progressing. Some people have the fear or the misconception that if you're taking a puberty blocker, that like you're gonna just be infinitely messed up. Like it's like this is often an argument I hear from parents of children and kids who know what their bodies want, what they need, but they're like, no, that stuff just messes up your kids. It's actually puberty blockers, those medications that I refer to, are actually have a pretty safe profile in terms of medications. because all medications have a safety profile, right, of risks and benefits. There haven't really been great studies that say one way or the other, like, oh no, this means in the future they're going to have like X, Y, and Z problems. It's actually not true. So puberty blockers, the only risk to be aware of is that it can impact bone density. So whether it stops the bone density where it is now, or you're not gonna, or there might be a slight decrease. So bone density, so that's like how thick and strong your bones are. And it usually returns to the normal range. Again, if you ever once you stop taking the puberty blockers, that's it. Your bone health will naturally rejuvenate. But knowing that that's a potential, right, is that your bone density could decrease because you're stopping the effects of estrogen, then what you would do is you would take vitamin D and calcium supplements. And so vitamin D, often it's like 1,000 international units. If you were to go to Shoppers and there's like a container, like usually one pill is 1,000 international units. So taking that once a day. And then calcium 1.2 grams or 1,200 milligrams. Again, like the concentrations of those things, if you were to go to Shoppers or really anywhere that sells vitamins, you could get those things. And the other thing too, when you're concerned, this information also applies to anyone that's menopausal, or they're concerned for their bone density because they no longer have menstrual cycles. It's the same dosing as well, vitamin D and calcium, and doing weight bearing exercises. Because when you're doing something like you're lifting a weight, or you're walking, or you're running, your bones are having to resist the force of gravity. And so whenever your bones have to resist something, even if it's just gravity, that's how your bones break down and then regrow. So in order to get your bones to be stronger, it needs to break down first. And in order to do that, you need to do things under resistance. So even just lifting weights, probably some of the best thing that you can do to keep your bone health intact. Um, uh, and I think there's actually a risk to not having the access to puberty blockers early on. And I definitely tell healthcare providers that not providing it is not a neutral option. That can actually cause quite a bit of harm. And there's just the increased risk of mental health and suicide ideation. Like the sooner that we act on when people are needing specific changes in order to feel like their gender is affirmed, the sooner we act on those things, the better. Even though in society, often the conception is like, okay, but we want to wait because maybe this is a phase, maybe they're going to change their mind, or like, like they don't know what they want, they're just kids. And it's just in my clinical practice, and that's just not how it works. People, the sooner they have access to things, the sooner we have like improved mental health. I think the longer we withhold things that people are wanting, the worse it is, right? And more issues develop. So that's just some things to consider. If you're, hey, should my kid be on a puberty blocker? It has a very safe profile. And there is actually probably far greater, because the bone density issue of taking a puberty blocker is a theoretical risk that is possibly fully reversible. Developing depression, anxiety, and then becoming suicidal is a far greater and imminent risk than a theoretical risk of a low bone density. That's how I think of things. That's usually how I think of any intervention, is like, what is the risk benefit? So definitely if you have kids, grandkids, or people in your life who are interested in puberty blockers, just like help them on that journey, because oftentimes it can be quite life-saving. So is there another way to suppress testosterone without taking a pill, right? So you don't want to take the spironolactone or the Andicur. What else can you do? So getting rid of the source of where testosterone comes from. So that is it's a surgical process. It's called an orchiectomy. And so that's essentially when you have one or both testicles plus the spermatic cord, the cord that is attached to the testicle. Essentially, you get those things removed, because that's the source of testosterone, right? When you get rid of gonads or people's internal organs, then you're really able to for the most part, reduce, you don't really need as much anti-androgen blockers, right? Because if you're getting rid of the original source, you can actually decrease your dose. And if you are taking estrogen, if you're getting rid of testosterone, which is the thing that's directly acting against, then you also get to decrease your estrogen dose. Something about the surgery, so it is irreversible. And does result in permanent infertility just because you're no longer you're getting rid of the thing that produces sperm, right? So that's something to consider for a lot of procedures in trans health, is just being able to, like, whether in the future you would like to have children, and if so, then like talk to a sperm bank and get your eggs frozen, stuff like that. If you don't want to have to make that decision, it is quite an expensive process. The province of Ontario does cover, I think, half. It just like OHIP. I think it's honestly like a $15,000 process. They cover 7,500. So still very expensive unless you have drug benefits. But almost so interestingly, getting rid of the thing and having almost no testosterone, um, if like we were to just leave it point blank and then you never continue to take testosterone, but we remove the source of it, even though you're trying to have usually more feminized features, you also have a risk of osteoporosis. Just everyone has bone osteoporosis risk, regardless of the situation. So just if you are going to do this process, it is ideal to be on testosterone. If not, do the things I said, which is vitamin D, calcium, weight bearing exercises. Okay. And so the side effects of having low testosterone, this is true whether you get the surgical process or not, is having erectile dysfunction, so not being able to maintain an erection, decreased sex drive, and decreased energy. The decreased energy part, for the most part, people are like, yeah, that's not ideal. But everything else on that list, like that's the people usually want. That's actually, it is more gender affirming for some people who are wanting to do more feminizing hormone therapy, to not have random erections like that. That actually is beneficial, and for the most part, what people want. That's the intention when they take it. So this process, the surgical process that I was talking about, so it's usually just a day surgery. We talked about the sperm bank. Something to consider is that if you are wanting to get rid of the scrotum, which is the thing that contains the testicles, this is extra tissue that in the future, you might in the future want a vaginoplasty, which I'm going to talk about next, but that's the creation of a vagina. So if you kind of get rid of the extra skin, then you won't be able to use that in the future for the lining of a vagina if you were to want to create one. It's okay if you do get rid of that skin, but anytime different, especially when we're recreating something, like we're trying to create like different body parts that didn't exist, you often would take skin from your thigh. You would do a skin graft if you did get rid of that. Vaginoplasties can be done at the same time, and something to consider: no heavy lifting for 2 to 4 weeks. But in terms of recovery, it's really not as bad as some of the other surgeries that I'm going to talk about. It's actually all surgeries have risk, but in terms of complexity and recovery, I find that this is one of the easier ones. Something to consider. I never say that there's like a true, like, oh no, you can't have gender reassignment surgery if, because technically it's still an informed risk, right? But if you are someone who has heart attacks, you have cancer that depends on estrogen, right? If you're taking estrogen and your cancer literally feeds off that, then usually it's not ideal to have both of those things together. But again, not impossible, right? If you had end-stage chronic liver disease, or if you can't provide informed consent. That's true across the board. If you ever had those issues, you would just kind of reconsider getting any type of surgery, not even just this type of surgery. So these are things that are available, tuckers or gaffs. So that's essentially a type of underwear that smooths and flattens the appearance of the groin. So these, I believe, I talk about at the end of our slideshow, but NIHB, non-insured health benefits, if you have a status card, if your doctor writes a prescription, these can actually be covered. So you don't have to pay out of pocket for them, which is really nice. So estrogen. So if we're not doing the puberty blockers, which they're not really puberty blockers after a certain amount of time, because you will have got through puberty, but we're just blocking the testosterone. And if we're not getting rid of the source of testosterone, Another option to consider is actually just is starting estrogen. So I think all forms of estrogen are covered. All the ones I'm going to talk about today are covered by status. And then the province has like an exceptional access program, and it covers, I think, I want to say the pill and the gel and the injection. So yeah, so this is the first option. So you can take a pill. So that's usually taking once or twice a day. There's the estrogen patch, which you apply 2 times per week. There's estrogen gel. So people usually apply that to their calf, inner thigh or stomach, essentially anywhere that has like a bit of extra fat, because that's how it gets absorbed. So there's the estrogel that people can use, and then the actual estrogen injection, which is a needle that's every week or every 2 weeks. It really just depends on the types of dosing. So these are the formulations of estrogen that are available to you. And some, right, like would probably be good for you and some probably wouldn't. If you have a needle phobia, then I would recommend against the estradiol. If you're someone that like really reacts to like you're just really sensitive to different like face products or creams, then estrogel might not be the one for you. Same with the patch. They all have an equal risk profile, and one isn't really better than the other. They're kind of all the same in terms of getting you the effects you want, which are often these things. So the first thing when you start taking estrogen that people notice is one, they're not going to have as many erections. Their sex drive is going to be decreased, and the scalp loss that naturally occurs in this situation essentially stopped. It's not like I'm not guaranteeing you that your hair isn't still going to fall out, but that is like some of the first things you start to notice. Your skin might be a little bit drier, a little bit thinner, you sweat less, people start to develop buds beneath their nipples. But there's kind of, so this is the physical effects that maybe you're aiming for, whether they're reversible or not, and how long is it going to take in order to see those things. So I usually just like to talk about the things that are irreversible, mostly because everything else is like, for the most part, variable, or we have other surgeries that can undo them. So one of them is that if you were taking estrogen and you had some breast growth, right, that's irreversible in the sense of whatever natural breast tissue is there. Like we can't make it go away unless we're physically removing it. So that's something to consider. Same with body fat redistribution, but again, you could just have surgeries that move body fat to the different places that you want. But that's just the idea that like if you're trying, because usually in feminizing hormone therapy, you're wanting to have like more fat in like your stomach and your thighs and your chest area. So if that fat redistribution happens, it's really hard to undo it if you were to stop taking estrogen. We talked about this. So avoiding medications, mostly if you have like heart or liver issues, just talk to your doctor. I mean, you're going to be anyways, but just then make an informed decision about whether it's right for you. Often a question that I get asked in clinical contexts is, would you start the anti-androgen stuff or the estrogen first? So usually what people will do, this isn't like how everything is done, but usually how most people do it is they'll take the anti-androgen for the first like 1 to 3 months, and then they'll start the estrogen. So, sometimes you can start those things two at a time or both at the same time. Sometimes though I find that difficult because if you're having a reaction to something, we don't know if it was the anti-androgen or the estrogen. And the other thing too is that some people can get the intended effects they want by just taking the anti-androgen. They don't even need to add estrogen. It's not like totally, yeah, fixed. So you can start both or one at a time. But to me, like the less medications you have to take in order to feel good in your body, the better. So I would personally want to go with the anti-androgen and see how much benefit I could get out of it, and then see if I needed estrogen. Another uh, surgery that is available and is covered by OHIP. Towards the end of the slide, I kind of talk about surgical procedures, whether they're covered, how they're covered. But it's something called breast augmentation, so or breast implants, as or chest implants, as they're colloquially referred to as. So that's essentially implants so they get inserted behind existing breast tissue, and the idea is to try and enlarge one's breasts. So something to consider. I mean, benefits, right? If having a larger chest makes you feel more yourself, then you're not going to need as much padding in your body, or you're not going to need a breast prosthesis, or maybe you are, but you don't need as much of it. Some things to consider that any skin or breast changes as a result of the implant surgery can't be undone. So, like, see how like on the left hand side, but then the skin is getting stretched. So that skin stretching as a result of the implant that's going in there, you can't really take that back, if that makes sense, unless you're surgically cutting it off. But it's not like the changes will be undone. Um, if you wanted to go back, quote unquote, on the surgery. Implants also have like they don't last forever. At some point, they do need to be changed. So there will need to be a repeat surgery at some point. Also, if you ever wanted to change like the shape, size, location, that is also another surgery. Implants make mammography for breast cancer screening more difficult, but not impossible. It just means that. So some people ask, like, why would I, if I'm like, I wasn't born like with my sex designation as a female. Why on earth do I need to get breast cancer screening? And so this is true for people who are taking estrogen. So if you've taken estrogen for longer than 5 years, you then have the honor and privilege of falling into the category of people who need to be screened for breast cancer, because you essentially, if you've been on estrogen for at least 5 years, you have the same risk of breast cancer as I do, or anyone else that's cisgendered. So you do kind of still need to keep up with that process, even though maybe in your previous body or your previous experience of your body, you wouldn't have had to do that. But now we do. And it's good to take care of preventative health. And again, it's not impossible to get mammography. Can be more difficult. Mammography is kind of like where they're squishing down the boob and trying to make it as flat as possible, so that they can then see, okay, are there any lumps and bumps? And so because that process is a bit harder when you have something that could just like, squish, usually what they'll do is an ultrasound. So if you are a trans woman, but you've never taken estrogen, then you don't need breast cancer screening. This is only the case for trans women who have been on estrogen for longer than 5 years. Okay. Something to consider for this particular surgery. So time off work, usually 3 weeks or longer, depending on the type of work. I think the hardest thing for people, do not lie or sleep on your stomach/chest for 3 months, which if that's how you sleep all your life, like to me, this is the hardest part for a lot of people. Talk about like being like, oh my God, I can't sleep because I can't lay on the front part of my body. So that can be a difficult part of recovery, but not impossible. You can get pillows that kind of like help you still be able to lay flat on your tummy. So implants, depending on the type you get, last 5 to 15 years. And in order to qualify for the surgery to be covered and paid for by OHIP, the province, in order for it to be paid for by the province, you do have to have taken estrogen for a year and somehow prove that you weren't successful at getting your breasts enlarged. I don't know, again, who's monitoring this, where they're like, no, you got a little bit of growth. So unfortunately, you don't qualify for this. Or like, I don't know who's following up with these things. Nobody, I assume. So, but just on paper showing that you've been on estrogen for at least a year. So vaginoplasty, so that's what I talked about previously. So that's the creation where you're making a vaginal vault. So the vagina is not the outer part in this like photo here. This is a blanket that I think is hilarious because it was made to like, it looks very anatomically correct. Um, and people could be like, oh my gosh, why is that photo in there? I'm like, it's just a blanket. But so the goal of a vaginoplasty, so you're creating usually both. So the outside, which is the vulva, that's the stuff that we see on the outside, and then the internal canal, the part, the vault. And so how that's usually done is that you either are removing or inverting, which is kind of taking the skin of the penis that then gets internally put inside, right? Because you think of like something that's like round and then moving it inside of you. That's how you create the actual lining. And then the extra skin, like we talked about, can be you make the outside, so the labia, which are also colloquially known as the lips, so on the outside. And even people are like, well, I'm not going to have sensation. Like if I had a penis and now I'm getting a vagina, like I'm not going to have as much sensation. It's actually not true. You can use tissue from the tip of the penis to actually make a clitoris, which is one of the most sensitive parts of the body and has a lot of nerve endings. So there is, I think, a lot of artistry and craft into getting these types of surgeries done. A lot of physicians, surgeons that are really experienced at this, and there's a lot that's like coming out. And in these surgeries, I find are always improving. There's always something new, but this is the process for creating that. Um, Something to consider is that with vaginoplasties, you're kind of you're because of the skin type that you're using to create the inside part of a vagina, it's not going to be lubricating. So, what I mean by that is that vaginal tissue itself is self lubricating. So when we're creating a body part, it doesn't need or it doesn't self lubricate. So you are going to need lubrication. So this is sometimes a hard thing to conceptually grasp of like, wait, what? And it's because you're not going to be making the same amount of fluids. Something to consider again, if you're wanting children, consider sperm banking. Usually need 3 months off of work. So this is what I mean about like some surgeries taking longer to recover from than others. Something that's we've had people in the Gender Journeys program mention to us is that also when you get the surgery, right, and you like look down, the vulva isn't it's not going to just appear, if that makes sense. Like you're not going to look down and be like, wow, look at everything fully bright, because surgery takes a lot of time to heal from. The tissue is really swollen. You can't really tell what's going on. So it can feel really disconcerting and really like shocking to be like, wait, why didn't it look like this photo? I'm confused. It's going to happen. It can take anywhere from 6 to 12 months. So mentally preparing for that. There's usually some numbness for about the first year. It's really hard to say whether people continue to have numbness or whether it's going to go away. It really depends. And there is a need to dilate. So that's actually where you take something and you physically insert it into the vagina and you're trying to keep things open. So in the same way that, like vaginas dilate for babies to be born, or some people use dilation to have like less painful sex, that's something that you would need to keep up with to prevent the vagina from closing. This is technically true of anyone who isn't having something manually inserted into their vagina over time. The canal really does just start to close, but you're going to need to do that dilation process, usually for the every day for the first year. Then after that, it's just kind of weekly, or if you're having regular intercourse, then you don't need to worry about it as much and doing it on the daily. But yeah, douching, which is inserting water into the vagina, or a sitz bath, that's like when you have steam that's coming up to kind of, and that's again adding the natural lubrication and helping the tissue heal. Okay, what time are we? Okay. The next set of what we're going to be talking about is the masculinizing hormone therapy. So I'm thinking let's just pause for questions, see if there's anything that we need to talk about or answer. Feel free to anything, even if I haven't gone over it yet, but you're like, I just want to know this. And then I think we'll take our break here because the next section is it's going to be its own section. So that'll be the next thing we'll be talking about testosterone, different effects with that, what's covered for surgeries. And yeah, that's, I think, what we're going to be ending off with. But we're just going to take our 10-minute break here. So feel free to get up, stretch, and then we'll be back in 10 minutes. Hey folks, hope you had a good break. Yeah, so the next part of what we're going to be talking about is masculinizing hormone therapy and just like different types of surgery. So, the goal with hormone therapy is usually to reduce estrogen and to increase testosterone, with or without the intent to change secondary sex characteristics, like changing the amount of hair you have on your body, the amount of oiliness, stuff like that. Those are secondary. So, testosterone comes in a few different forms, actually. I'm going to put them up here. So technically there are three types of testosterone that are available in Canada, but these are the two most common ones that are used for this particular reason. So both of them, so there's the testosterone enanthate, and then there's the cypionate. Both of them, some people will ask, like, okay, which one's better? None of them are really like, not one isn't better than the other. It's just that the cypionate lasts longer. So sometimes people are able to like extend the length. Like instead of having to do it like every week, they can do it every 2 weeks. It just really depends on the dose. But both of them are really great. One isn't better than the other. So these are needles. So these are injections. Um, Usually, so these can be injected IM, that means into the muscle. And then, or alternatively, they can be injected sub-Q. Sub-Q is subcutaneous, that's like into the fat. So that's like in your stomach at the bottom here, or like under your arm, just anywhere where there's a bit of fat you're trying to inject there. The other, so the thing with both of these types of injections, so because the cypionate, I think the base oil is cottonseed oil, and then the enanthanate is sesame oil, which is interesting. So, also, if you're allergic to any of those things, something to consider about which formulation you're going to take. But because they're base oil, like the cottonseed and the sesame oil, they're super thick. It's very, very viscous. So it's not going to be irritating. But when you're trying to draw up this medication or you're trying to inject this medication, it's like viscous means it's thick, right? So you're like trying to have to push. So in order to reduce some of the um, barriers there are to doing this injection, something that I definitely recommend is if you warm up the vial of this in the palm of your hand, that reduces viscosity. That's true of anything, honey, anything that's viscous, right? If you just warm it up by moving it around in your hand like that, it's gonna be easier to draw up. The other thing is that you want to draw up the medication with a larger gauge needle, and then you want to inject with a different type of needle. And even just like simple things, like if you inject testosterone, like use a 1 milliliter syringe versus a 3 milliliter syringe, because if something's really thick and you're having to push, if you have a smaller one, it improves accuracy because testosterone doses you're never giving, because they're point something of a milliliter, you're never really giving more than a milliliter. um some cases you are, but like the max dosing of it, right? So if you improve the accuracy by using a smaller syringe, and you decrease the amount of force that you have to use in order to plunge the medication. So needle lengths like really depend on like what your body shape and style is. um, I think someone asked, so all of these versions, the testosterone injection and the testosterone gel, so it is covered by NIHB, non-insured health benefits, by a status card. Otherwise, through the Ontario drug benefit, you do have to go through the exceptional access program, and I believe it's only for the injections. I don't think it like you get limited use benefit or prior approval for the gel. But when you do have status, then those things are covered. Um, IM is pretty typical. So like when you do it like into your butt or into your thigh, or into your deltoid, into your arm. But a lot of people inject subcutaneously as well. It's actually thought to be less painful, and people are usually able to do that to themselves, right? Like The unfortunate thing with IM, I'm not one way or the other. There is a bit more evidence now that's come out. Granted, it's not a lot, that subcutaneous injections are a bit better than directly into the muscle, because they just have a greater half life. Drugs have half lives, meaning like what is the peak halfway through, what is the peak concentration? And so what they noticed is that when they put it into the fat versus into the muscle, there was more of that medication in the body because it was injected to the fat, which makes sense. So I think subcutaneous is quite a bit easier. Most people can manage it themselves, right? Because when you're doing an into the muscle injection, like you have to be 90 degrees. So like I don't really know people who can like have a needle and then go like to me that seems really difficult. It's like usually you would go to a clinic and have a nurse help you, or you'd have a healthcare professional do that for you because it's so difficult versus subcutaneous. One, people, when they do it into the fat, they usually do it twice weekly instead of the once weekly into the muscle, but it's just easier, right? Like all you do whenever you're doing an injection to the fat, it's so hilarious. But so if you have fat here, you literally just like pinch it. And so then you're wanting to inject at not a 90-degree angle, but 45, right? So you're not want to just be at the surface of the skin. You want to go a bit deeper than that. But you just pinch. The best way to do that is by like pinching up the skin and then injecting. There's also like a lot less infection rate, a lot less error when you do it that way. So sometimes you'll see on the vial it'll say intramuscular IM use only. I don't know. People use it subcutaneously and like nothing bad has happened. So even though the bottle might say don't only into the muscle, you can do it into the fat. And I think eventually the bottles of testosterone will reflect this. Um, Otherwise, there's the testosterone gel. So sometimes what people can do is you either can get little sachets, like little plastic things that just like have the amount naturally already in them, or you can get a bottle. So usually people are doing 2.5 to 5 grams daily. So either you're taking the little package with the gel that has that, or you're doing 2 to 4 pumps if you have the bottle. And when you do that, the dose of 2.5 milligram or 2.5 grams of the gel, that's 25 milligrams of testosterone. And so you apply this gel usually to like your shoulders or to your arms, or to your stomach once a day. So the other option that I have here, which is it's actually being phased out, which is why I didn't really include it as an option. One, because the drug company is going to eventually, as of October 2024, stop making it. But this is androderm. So this is like the patch. There used to be something called the testosterone patch. So in 2021, they started the drug company started the process of discontinuing them. AbbVie, I think, and they were pretty much the only person that made transdermal testosterone patches. So if you still have some, that's good. They're just going to be phased out, and you're probably going to have to move to something different. So I just kind of don't really include it in the options that are available because it's not going to be available for much longer. So these, there's also, you might have heard on the market, there's the testosterone medication that could possibly be like a tab, like a pill, which I think is ideal. It's not approved in Canada yet. And the other is the implantable, oh gosh, implantable device, like kind of the implant. Yeah. So having the implant that's where you're just having testosterone that's being released consistently throughout the day, all day for however many years. So that does exist, just it's not Health Canada approved. So, but could you go somewhere else and get those things? Wink, wink, nudge, nudge. Yeah, probably you could. If you're wanting those, I think those seem like more because people don't like taking needles. I don't know. I don't like taking needles. And the gel, some people have the critique of like, well, if you're around people, like you kind of have to be aware that if you put on testosterone gel, it's still a little bit on the surface of the skin, right? So if I were to like go up to someone and be like, oh, look at it, it's so nice to see you. I mean, I don't know who's doing that, but if you are, technically the testosterone on the skin were to rub onto your face and that were to happen multiple times, yeah, you might get a bit of like facial hair growth there. So that's the critique of like, well, I don't want you touching anybody because if the testosterone gets on you, and I'm like, you'll be fine. But that's a theoretical risk. So having a tab or having an implant where you could just like never think about it until it needs to be removed again and have high consistent levels is just so ideal. So I hope that happens quickly. The things, the side effects, the things that usually people are wanting to happen in terms of physical effects when they start testosterone is one, usually a deepened voice, increasing your muscle mass, facial body hair growth, stopping of the periods, the vaginal atrophy. So that means the skin of the vagina getting smaller, and clitoral enlargement. So, which seems like a bizarre concept that you would want that if you like, why would someone want that? But the reason why is because that particular organ being grown makes it easier for potential surgeries in the future. So that's why you would potentially want that. Um, the things that you're going to notice, usually the first changes people get when they start taking testosterone, it's actually kind of crappy because it's like your skin gets more oily. And like, because the first thing that stops isn't your period. It usually takes 3 to 6 months, even though that's like people are like, I want this to stop. It takes a while. So people usually get the pimples and acne stuff first as their change from testosterone, which I'm like, I'm so sorry. Versus the opposite, if you were taking estrogen, in the previous section I was talking about, your skin has become drier and smoother and softer. So I'm just like, I'm so sorry, people. Um, but yeah, so it having an increase in facial body hair, which probably isn't something intended that you're hoping for. Periods, though, menstrual cycles, moon times do take a little while. So if you, if after 3 to 6 months, so hopefully, if this is what you're wanting, period stopping 3 to 6 months, it's happening. If at the 6 month mark, you're like, holy crap, this is this is because it could be dysphoric, right? Gender dysphoric, to have a menstrual cycle when you are a man, and that's how you see yourself and that's how people see you. So the goal after that is that if you haven't reached the maximum amount of testosterone, pretty much what you would do is you might actually need a type of birth control that is known to stop periods, which technically you can be a trans man and still be on birth control. The amount of estrogen that is in um like over the counter birth, like, or sorry, OCP, oral contraceptive pill, like the pill if you were to take the pill, um or that didn't, one, there's pills that don't have estrogen, and there's different types of birth controls that don't have estrogen. But even if you did need to take a birth, like you're a trans man but you needed to take birth control and it did have estrogen, there really wouldn't be an effect on your testosterone. I mean, it might not feel the greatest mentally, but physically it's not going to interact with your testosterone. That's um, not necessarily true of the other estrogen I was talking about, right? Estrace, that's a very significant higher dose versus what's in a pill. So the other thing to consider is that your fertility is decreased when you're on testosterone, right? When you're getting testosterone. But technically, it shouldn't really be relied on for birth control, because reduction in fertility isn't irreversible unless you're physically removing the uterus and ovaries, which we're going to talk about that procedure. But don't assume because you're no longer getting menstrual cycles that you're just like not going to get pregnant if you were to potentially have intercourse with someone who would have semen or sperm that could then get you pregnant, because there still is the potential. The other thing to consider too is that some people, trans men, are like, actually, they want healthy pregnancies in the future. And so that can sometimes be reassuring that, like, if you were like, you could be on testosterone, and have been on testosterone for many years and still, um, become pregnant. So when you become pregnant, unfortunately, you usually do have to discontinue testosterone, which is a whole thing of itself, right? To stop taking the thing that makes you feel like you. But That's why we can see like trans men have pregnancies. That's why it's ideal when you're referring to pregnancies, talking it about it as such versus like, oh, moms, like pregnant moms. It's like it's pregnant people because trans men can become pregnant if they would like to. Um, and it's, yeah, happens all the time. So these are the changes. The things that I want to just mention that are irreversible when you start taking testosterone. So if and when your voice starts to deepen, that part is not irreversible, right? Unless you were to do vocal coaching, but even then, the size of your larynx or your like voice box, like the physical size of it changes, so that can't be undone. So that's just something to consider. The other people say irreversible, but I'm like, technically, you could just get your hair burned off. But facial body hair growth, anything that you sort of get, like the natural hair follicle, that is irreversible unless you're doing electrolysis, right? Like laser hair removal to get rid of it. Um, and then the other thing is that clitoral enlargement. So if you were to take testosterone, that body part, that organ is getting bigger. That is also like if you stop taking the testosterone, it's not going to go back to how it was before. That's what I mean when I say irreversible, is like what you had before. It's not going to go back to its original form. It's going to stay what it is. Otherwise, everything else is fairly reversible. If you ever wanted to stop taking testosterone, I often find that that's not the case. Where people are like, "Oh, I'm so glad this is reversible because after 20 years of taking testosterone, I no longer want it." Like, I personally, I haven't had cases like that. Clinically, that does happen, but it's just it's very very rare. So similar to avoid taking testosterone. So avoid taking testosterone in pregnancy or for chest feeding. Um, Again, it's not impossible, but the way testosterone works in pregnancy, I think it's like more likely hyperandronergic. So there's like only a certain type of sex of a child that you could reproduce while still being on testosterone and trying to become pregnant. I can't remember exactly what it is, but there's like technically that effect. Um, so avoid taking testosterone. If you have a type of cancer where like you would be feeding, if the cancer is testosterone based, then you're essentially like taking it, feeding it. Heart attacks. This is true like more specifically for this than the estrogen, is that if you have poorly controlled psychosis or acute homicidal, like being homicidal, wanting to kill people, I mean, there's, I think, some other issues that we would need to go through just generally, but taking testosterone, people are like, oh, you got the like roid rage. That's a legit thing. It's actually, so taking testosterone, we would have, until that was, dealt with, you would avoid taking that, because that is actually a thing. It does increase, your irritability and your quick, it doesn't make you more angry as a human taking testosterone, but it does increase the trigger in which it needs for you to become angry, right? Like it's just a lower threshold versus before. um so the types of surgery available, I think I'm only going over like three of them. There's a lot more. All the things that I'm talking about though are covered by OHIP, your health card. So there's the chest reconstruction, locally known as top surgery. So if you're a trans masculine and you have top surgery, which is usually the removal of breasts. So in the process, you can kind of see here. So there's the mastectomy part. So that's removing the actual breast tissue. Um, Usually, you're also removing the nipples and the areolas. The areola is the dark thing that's around. The nipple is like the actual, like small tidbit that's in the middle. So you're, unless you want to keep the size you already have, but you're usually resizing them and then reattaching them. So then what you're left with is your like the placement of your nipples, the chest, breast tissue has been removed, so your chest is a lot flatter, and then this part here, the contouring of your chest wall, so that's where you kind of like maybe you want to make like the sternum like a bit more outwards and you want to like tuck this in more. That's what they mean by contouring. That part of top surgery is not covered, so that would be like you would pay the surgeon extra in order to do that. It's kind of like what you're left with after the incision is like done up, because they have to go under the chest tissue. So sometimes what you might see are like scars, like under someone's chest, and some people that they become conscious, like self-conscious about in their body is like the way those scars heal. So something to really consider is that if you want ideal healing, it's really best to, if you're a smoker, to stop smoking for that very particular reason in terms of wound healing. The darker your skin, usually, like if you're just someone who develops keloids, which is like, you get a scar and it's like really thick and bumpy, um, that's something that can definitely be the case. If your scars bother you, like they make you self-conscious, something to do is that there is such a thing as scar removal, um, which is really just breaking down scar tissue. So, like something that I do for some of my trans masculine clients is, because I can break down with a needle, like just a regular needle. I don't advise doing this if you're not like trained in how to do this, but scar tissue release is a thing. With needles where the tissue is fibrotic, that means it's really thick and you're just very painful, right? Because it's skin that hasn't come together well, hence why it's sensitive, or there might be no sensation there at all. Some people ask, oh, if it's sensitive where those scars are, or I don't feel a sensation, is that ever going to come back? And it really just depends. Nerves can technically regrow back. It just takes very, very long. That's like the one thing in your body that takes the longest to heal. So is nerves versus bones or like skin cells, all that stuff. Nerves take a really long time, especially nerves that are at the top layer of your skin. But anyway, so if you're concerned about the way the scars look, you can do scar tissue release via a needle. So getting a provider or like a practitioner to do that, or like Google YouTube videos. People do this for their pregnancy scars as well. It's essentially where you're just like pushing and you're trying to break up that fibrotic tissue with the pads of your finger. To me, that's not as effective as just like getting right to it. But it's going to look more angry once you do that to your scar, but then it's going to heal and you will have a less visible scar. If your scar is there, don't bother you, then this doesn't apply to you. It's just for people if they're like they don't like what it reminds them of, they don't like the way it looks, they don't feel great. Those are options that are available to you. When you have top surgery, your risk of breast cancer is low, but technically not impossible. So sometimes I had one patient who was like, "Oh, I'm so happy! Like when I'm 50, I don't have to do mammograms." I was like, "Oh no, I'm so sorry." Essentially, no one gets out of cancer screening prevention. I will always recommend it, and you don't get out of it because your breast tissue is removed. Um, it greatly lowers your risk of breast cancer. So, I mean, that's great, but it's still technically possible. If you're a transmasculine woman, or sorry, transmasculine man, and you haven't had top surgery, like you still have the breast tissue in which you were born with, your breast cancer risk is similar to just like cisgendered women in the public, the general population. So either way, breast cancer screening still a thing. I'm so sorry. Um, it's irreversible again, like just because, I mean, I don't know, you could technically, if you wanted it back, you could just stick an implant, but you're not able to get the original form in which you had. There's the decreased ability to lactate or chest feed. There again can be some numbness, especially in the nipple areola area. That's definitely a higher risk when you're having the double incisions and you're removing both breasts. Scarring, you can manage that. We talked about that, and then just the cancer screening. So when you're getting top surgery, the more chest tissue that you're starting with, the bigger and more aggressive the scar has to be. Hence, that's what can often lead to permanent scars. The other thing to do to avoid scars, not just for top surgery, any type of scar you have, the way to make it heal better and for scars to look less prominent is to avoid the sun or put sunscreen on it. So like if you're going out and you don't like that, like your top surgery scars are available and you're going swimming and your top is off, rub sunscreen there. I know it's not a typical place you would rub that, but that is, if you don't want them to get darker, that's what you have to do, sunscreen. Some people, when they get top surgery, they need surgical drains. That's like little tubes that have these, I don't even know, like little container cup things. It's essentially, so it's because when you remove tissue, your body, first of all, is like, what's happening? So it's going to start to put things there like pus or like, right? Because it's like, why is there empty space? And so it's going to try and put stuff there. So oftentimes on the side or on one corner of where they did the incision, there might be a little bit of a drain just so that, like, if your body does try and essentially release fluid or put something back there, it's not going to be putting like breast tissue back there, but if it were to fill with fluid, you would have these drains, and it's usually just for the first week. Not everyone has them. The other is usually wear like a compression band for the first month. And then, so once you get top surgery, avoid driving for 2 weeks and then limiting arm movements and really lifting anything. So sometimes that can be hard because it's like, this is as far as you can go. So if you, like, I don't know, have a job where you're like lifting things up, like you can't, it's just going to rip open the scar. So you really, your arms have to stay, like, even driving for some people, like you just, right, because your arms are like this, you just really want to keep them down because your chest tissue is connected to your pec muscle, and anytime you move your shoulder, right, like those, that has the potential to um, essentially reopen the scar. Another procedure that some trans masculine people might be interested in is clitoral release. So this is essentially where a penis is being created with enlarged clitoral tissue. So obviously you're, numb for this, but the ligaments that are around the clitoris, you're essentially removing that so that there can be an extension of something. Um, so usually what you, this procedure I find is often done in conjunction with something else. So whether that's a vaginectomy, which is where essentially you're removing the vagina, or you're creating a scrotum, like there's usually more parts to this than just this. But again, you're creating like penile tissue that's there, but the urethra is going to stay in the same spot, right? So it's not going to be like a penis, where there's the urethra coming through it. It's gonna stay where it is. So one, I mean, the great thing about this is that, you're creating a penis. Usually, people will ask, like, is it functional to have sex with? And it just really depends on like how enlarged that area got before you started, right? Because if you think of it, when you look at a clitoris, what's behind it is a lot more than what we can see. So that's why you're like, wait, how is this being made into that? It's because the clitoris is like actually quite a bit larger than just the tip that you see. There's like all of this stuff that's behind it. So that's how it's being created. Um, but yeah, so in order to facilitate that, usually you're going to want to take quite a bit of estrogen or testosterone before to make that area as large as possible, so you have more tissue to work with. Um, let's see here. Yeah, so the thing that you're making though can be used for penetration. I find that it's usually like, unless you're just, I don't know, really blessed and you got a lot of tissue, the penis usually is not large enough for insertive or penetrative sex. If you wanted that, then we would be talking about the phalloplasty, which is what's coming up. But this would just be to just have body parts that can still be used, and still, like, you still, people can have great sex lives from this. But if that's your intended effect of like being able to have penetrative sex with it, likely not the procedure for you. um and then let's see, side effects: inability to have receptive vaginal sex if vaginectomy is performed. Yeah, so some people, again, they're usually getting another procedure in addition to this release. But I find this process is definitely like a lot less scarring and a lot less complications than a phalloplasty. And the other thing too is that you can also get testicular implants. So that's where, like, you're actually creating like the shape. It's, again, similar to like how it's a breast implant. You create a tissue, like a tissue and skin that you can then insert implants into so that it has the form and shape of testicles. But yeah, so some things to consider: taking testosterone, try and enlarge the parts that we need for at least 2 years. You need to be off work for about 7 weeks, and the urethra stays where it is, so you can't pee while standing. So if that's important to you, like you're still going to have the urethra here versus on like the tip of a penis. So if it's important to who you are to be able to stand up and pee, again, this isn't the right procedure. You would do something else. So metoidioplasty. So this is where you're using the enlarged clitoral tissue to create a penis. So again, the ligaments on the outside are cut so that you're able to create more of a shaft. And so this is where you are kind of redirecting the urethra, which is like the pee hole. You're extending that into the tip of the penis. So some people, if they're wanting, like that's important to them to be able to like stand up and pee, without a device helping you, then this is what you would do. Let's see. So there's definitely a better chance of maintaining sensation to the penis when you do this process versus a phalloplasty. So there's kind of like three different ways in which you could make a penis. The clitoral release, like just the release itself, this, which is going to give you a bit more length, and you're going to, because you're redirecting the urethra, you're going to be able to stand up, still maybe not necessarily able to use for insertive penetrative sex, but some people, I don't know, work with what you got. Maybe you can do that. But yeah, that's the main difference between these two, is where the urethra or the pee hole is coming out of. Again, you're taking testosterone. You can add prosthetic testicles at the same time. Something for this part, right? So there's obviously more complications because when you're redirecting the urethra, urethra is connected to your bladder and it's connected to your kidneys. So when you're redirecting that, people usually need a urinary catheter for the first few days. That's like where there's like a tube that's in the tip of the penis in order to help you pee, just because like things are rerouting, right? Like you have to figure that out. And it's definitely possible that you might need a revision surgery. That's where they go back because something has happened. And it's usually related to the urethra because it can either become like closed or like kind of have tissue, scar tissue on the inside. And that's also why you have the catheter, right? Because you're just like dilating and making it so that it's not going to close up, because that would be very bad if the pee hole closed, because then all that pee would back up into your kidneys, then your kidneys would get swollen. Like it's just a whole thing. So to avoid that, we just do the catheter for the first few days. Not pleasant, but like it'll be over with eventually. Majority of people I find, if they're getting or they're trying to have the creation of a penis, this is usually the process they're getting, but there's usually a lot of steps that happen before you get to this. So one is that a hysterectomy, which is the removal of the uterus and the removal of the ovaries, is going to be required, right? Like if you want this process, you have to have vaginal removal usually. You probably are going to want to create a scrotum, and you're going to have to remove the organs that were there before. So it's kind of not like you, and you wouldn't get this done all in one shot. Some people are like, wow, they're doing this all at once. No, this is usually like over a period. This particular process is usually 4 or 5 different surgeries that's happening over 1 to 2 years. So it's not like a bam, we're getting this all done at once. It actually does quite take a bit of time. But this is when you're trying to create a penis that is large enough to allow for penetrative sex. So you're creating the penis, the pee hole, the gland, which is the tip of the penis, scrotum with testicle implants. Usually, or for some people, they get insertion of an erectile device, which means that like you have something that can help give you an erection, like a pump almost. Plus, you're removing the vagina. Again, lots of different processes that are happening. Some people can get scars, right? Because you usually you do need, unless there's like, I don't know, a ridiculous amount of tissue that you're able to utilize. Some people are going to need, that's why there's these little patches here. You usually need skin from the thigh or the forearm in order to help create like the outside part of the penis. But again, like the skin is going to grow back. Like people get skin grafts all the time. But there will be a scar wherever you get a skin graft. You need to get the hysterectomy surgery 6 months prior, so your uterus removed. Usually, I think my next slide is talking about this. I'll just wait. You do have to quit smoking 6 months before because otherwise the healing is just terrible. I mean, I guess you could theoretically still smoke, but I don't know. To me, it's not worth the complication of healing afterwards. If you want skin from your forearm or for your leg, right? But you're like, oh, I don't want hair there. You have to laser remove that for 6 months before, right? Otherwise, there's still hair follicles on this part of my arm. So if I'm moving it to my penis area, then that same hair is still going to be there. So if you don't want hair on the outside, like skin of the penis, then you have to get laser hair removal, and then they'll take that skin and use it. Again, it's 4 to 5 surgeries over a couple of years, and based on each surgery, there's going to be different recovery times. So if you're not taking testosterone, but you're wanting, so either you're wanting to reduce the amount of testosterone you take, or you just don't align with the fact that you have a uterus and ovaries and fallopian tubes, you get those removed. So hysterectomy, removal of your uterus, salpingio-oophorectomy, which is just a mouthful to say, salpingio-oophorectomy. So that's where you're getting the fallopian tube and the ovary removed. So it's irreversible. It's permanent infertility, right? Because the thing that's creating your potential to have children is in the egg. So you're removing the eggs. Some people just get hysterectomies and they still keep the ovaries. The issue, though, is then you're not getting rid of the source of estrogen, because estrogen doesn't come from the uterus. It just means that you're not, for sure, not going to be able to get pregnant because you don't have a place for a baby to grow. But technically, if you're not removing the ovaries, your body's still going to be producing estrogen. So the amount of testosterone you're taking is still going to have to counteract that, which isn't terrible, but it's not, it's not ideal. When you have no estrogen production, and you were used to estrogen production, you're definitely at a higher risk of osteoporosis if you're not using another type of sex hormone, right? Like if you're just doing this process but not continuing testosterone, then your risk of osteoporosis is higher. And again, calcium, vitamin D, weight-bearing exercises. I'm so sorry, I sound like a broken record, but like that's what you need to do, everyone, for your just to reduce the risk. So let's see here. Yeah, the one thing about hysterectomies that people usually like is that you're not going to get menses, and you're not going to get menstrual pain, and you're not going to get breakthrough bleeding, right? Like, because you're like, oh man, the amount of testosterone I'm on, like I'm still getting this like extra bleeding. This sucks. And it's like, no, if you remove this, then you're not going to have this concern. If all you did, like say you're a trans man and all you did was have your uterus removed, something to consider is that your uterus is free floating, which sounds really weird, but the only thing holding it up is your pelvic floor. So it's not like our abdominal or stomach cavity, right? Where there's a clear end here. It is free floating. So when you remove the uterus, something to consider is that there is the potential for your bladder to collapse, right? Because the uterus is here and your bladder is here. So if your bladder doesn't have something to push against, it's like a deflated balloon. So you're trying to pee from like a deflated balloon. So that's where people get incontinence issues, or they're like, oh, I pee all the time, but not all the pee comes out, blah, 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 blah. And like this also happens for like anyone who's had a hysterectomy. There's the potential for that prolapse, meaning for the bladder to come out of the vagina. Doesn't happen often, but it can. And also to have peeing issues, unless you're going to do all the other stuff that I talked about, where we're redirecting the urethra and we're creating a penis, right? But if that's the only thing you did, something to consider. Let's see. So allows for vaginectomy, sclerotoplasty, total hysterectomy. Okay, I covered everything there. If you're wanting children, consider egg freezing. If removing ovaries and not adding hormone, if you're not adding a hormone like estrogen, you will get hot flashes and menopausal symptoms. So, which sucks. If you talk to any menopausal person, they'll just be like, this is the worst. But yeah, because we're removing estrogen and you're not replacing it with another type of sex hormone, even if that sex hormone is testosterone, it's not even like you have to replace it with more estrogen. You just need some type of hormone, then you're going to get hot flashes. Please stop smoking. So just some things to know. We're like just down to the last like three slides. And this is just about the surgical portions, is when you, in order to get the surgeries that I've talked about, you need prior approval, which is its all set of process. Don't go out, get the procedure, and then try and get OHIP to pay you back. It's not going to happen. So you need the approval before getting the surgery. Otherwise, it's not covered. For some people, they're like, I don't want to wait for this. And they can't wait for this. It's like do or die. Like they feel awful in their body. They need it done. OHIP is not going to cover it. I know because I've tried multiple times to get this, where like someone was like, well, I went and got it done here, but like why? And OHIP's like, no, it wasn't previously approved. Therefore, you're not getting paid back. So just something to keep in mind. To be approved for genital surgery, any of the ones I talked about, you need two assessments recommending surgery. So one, usually from like a doctor, nurse practitioner, registered nurse, psychologist, or registered social worker. So one of them has to be from like a medical care provider, and the second can just kind of be from like, any, like it could be from a psychologist, a social worker, so anyone else that can sort of like help you manage and navigate forms. And so in order to have access to the surgeries, you need to have a diagnosis of persistent gender dysphoria, which I have a lot of thoughts and feelings about. So that because gender dysphoria is in the DSM-5 curriculum, or yeah, DSM-5, which is all of the mental health psychiatric diagnoses. So is it really a psychiatric concern if your gender is not aligning with the body parts you have? I don't think so. But in order to qualify for services, you need to have this diagnosis. Even though dysphoria assumes that the person, like, it's the person's fault that their gender isn't matching. So it's problematic in so many ways. So if someone is saying to you like gender dysphoria, most times it's literally just for the form. It's not because like you are a confused individual, even though that's what the diagnosis says, and it's not because it's a psychiatric issue, or you are now a psych case because you want to be trans. Unfortunately, though, like just bear with us because that's what we need in order to get the funding. And it's really messed up. And also, it's not a psychiatric diagnosis. But, anyways, you have to also, in order to get any of these surgeries, been on 12 months of continuous hormone therapy, unless the hormones weren't recommended. Like, we were like, no, this person has cancer, that if we give them estrogen, that's going to feed their cancer, then they'll be like, okay, you don't need to take hormones for like a year. We'll just do the surgery. But you need to have demonstrated that. And then I'm so sorry for this recommend. Like you also have had to have lived 12 continuous months in the gender role you identify with for genital surgery only. So that's not, anyways, it's messed up, but the things in order to get things covered, otherwise it's thousands of dollars. This is what we need. And I'm sorry for that. Yes, we need the prior approval. Once you get that approval, because it's like you submit the forms and then it's once you receive the forms back, then from that period you have 2 years in order to get, like, it covers you for a 2-year window for you to be able to get that surgery, right? Otherwise you have to apply again. Most people get their surgeries at like Toronto or the Montreal hospital. Like there's pretty much Toronto and Montreal are like the main places where people get these surgeries. But multiple procedures can be applied for on the same form if they're going to be done by the same provider. But say you want the hysterectomy by one and the phalloplasty by another, those are two separate forms, two separate applications, two separate waiting processes. But yeah, all of the things I mentioned here. So breast removal, breast implants, creation of a penis, removal of vagina, removal of testicles, creation of a vagina, having your uterus removed. So all of these things are OHIP funded, which is great. The things that aren't covered by your health card is liposuction. Say you wanted fat I mean, that would just be nice generally. I would love for that to be a thing, but it's not. Same with electrolysis, right? Like if you want the laser hair removal, the chest contouring, hair transplants, if you were concerned, like, because you're taking testosterone and now you're starting to like, you maybe were already destined and doomed to have hair balding and hair loss, and that affects you and you feel really upset about that, getting hair transplants is the way to fix it, but it's not covered. Same with an Adam's apple. If you have a really prominent one and you don't like the way it looks, you can get a tracheal shave. It's just not covered. If the sound of your voice, like it bothers you or it's not aligning with who you are, there is voice modification surgery. There's also voice coaching. So like if you don't want the surgery, but you like there are tricks and maneuvers for people who like teach singing lessons, like it's literally called voice modification, vocal coaches, and they can help you so that your voice, maybe you want it more higher pitched or you want it more lower pitched. If you wanted your chin, nose, cheek, or buttock implants aren't covered, any travel involved in getting the surgery. So in theory, OHIP covers it, but in order for you to get to Toronto, then stay overnight, then have the recovery process, for the most part, that isn't covered. For us in Northern Ontario, it would be because we have the Northern Ontario Travel Grant. It's not even a big portion that's covered, but there is a portion. That's not really true of people in Southern Ontario. Like it's just to get to the surgery, you have to pay for that. Okay, so these are the two main hospitals that people use in order to get these procedures done. They're like pretty much like the best places in Canada to get these things. Chest binding, I just wanted to go over some safety things for chest binding because sometimes I see this and it can be a bit worrying. But so chest binders, so these are, so in this case, these are like shirts. Some people have like actual bands, some people use tape. But something to consider is that when you're binding, you really want to make sure your nipples aren't pointing down, like especially if you have like there's sagginess, there's length to that, so you want to actually, this sounds weird, but like lift the chest tissue up so that your nipples are pointing this way and then bind your chest, whether you're putting on something that like is constricting or you're doing an actual band, because what you're doing is you're really damaging the tissue in the skin, you're pulling it down, and it's going to affect your future top. If you ever wanted top surgery, you're creating this excess stretch, and that's going to make your surgery and your scar less ideal. If you're not getting top surgery and you're just going to be doing binding for your whole life, then that doesn't apply to you. But making sure that, yeah, breasts are facing forward, your chest is facing forward. It's just definitely a lot safer. It's not always possible, but if possible, try not to bind for more than 8 hours a day, which is a really complicated thing to say because when people's, if their chest isn't flat and they're, and then seeing chest tissue, that can feel really awful for some people. But ideally, if you could like not sleep in your binder, just because like it is constricting how deep of a breath you take. Your diaphragm is being constricted. So you're great. So people are like, I want the tightest binder possible because I want that as flat as I can get it. But if it's like creating marks and it's like so tight that you can't take a deep breath, you will develop atelectasis, which is where your lungs, because they're not expanding fully, fluid starts to build at the bottom. So if you can, try to have a bit of time throughout the day where you're not in the binder. I try not to sleep with it. Maybe if there's even a day where you can have it like off. I'm never prescriptive about how people want to use their binders. It's your body. But like what I would say is don't go for something that's not your size. Like maybe you're supposed to be a medium, but you're like, no, I want extra small so that I can have extra binding. Don't do that. It's just, there's so many health issues related to that. Same with body or gender tape. This is true of any time you're trying to tape something. But usually if you're going to put tape, you want to like cover the nipple with cotton. Because otherwise you're gonna have to take that tape off and it hurts because you're like ripping off the areola nipple stuff. So put something there, do the tape. Usually you peel the edge and then you kind of like push to the side, so that you're making that flatter profile. You usually do another piece of tape in order to like have that piece of tape stick. Depending on your cup size, you're gonna need a certain amount, like you might need more or less tape. But yeah, usually I find like body tape is actually kind of nice because you can pat dry when you're done showering. But any type of oil is going to make it come off. Things that are covered by status cards, if you have a status card and a prescription, bra inserts, a brassiere for a bra insert, and compression or chest binders. Also gaffs or shorts, so the things that like make the front tissue that you have, making it more compressed so it doesn't look like there's like a penis outline. Female urination aids, I don't know why they call it, urination aids, packers, which is a phallus. So that's like a silicone based product that is in the shape of a penis that people can keep in their boxers or their underwear, so that like when they're wearing pants, you kind of have like a bump there that looks like it. Packer securement, so like a strap or a harness or a brief. And then vaginal dilators. So if you were to ever get the process of a creation of a vagina, the thing to dilate with is covered. Okay, we did it. And we have 9 minutes to spare. Okay, and we have some questions. So perfect. I'll just pull those up and take a look. But that's everything I have to talk about. Okay, I cannot read that too.
I'm wondering if a trans male would have experienced gender dysphoria prior to transition, but still want to retain the ability to become pregnant. Sorry, this is an ignorant question, but that's confusing.
Can I just move my computer so I can look at the question? I'm like, I can't see it. I'm struggling to see. Okay, I'm wondering how a trans male would have experienced gender dysphoria prior to transition, but still want to retain the ability to become pregnant. I'm sorry if it's an ignorant question, but I find this confusing. Yeah, and I guess it's maybe why it's a bit confusing is just because it's maybe not the experience that we might have with our body. So some people might not they might be a trans male but not connect to the experience of being pregnant, but connect to the experience of having a child. And they want that ability and they don't want to have to use like a donor. So for sure it can be confusing if that's not your experience, but it is definitely possible because you could still be a man but want to deliver a baby, or to be pregnant or to be connected to that, right? Because pregnancy isn't inherently female, even though that's how like society kind of has socialized us, right? Like there's like the baby showers for moms and all of this stuff. But you might, as a parent, identify as a mom or a dad, or you might not be either of those things, right? People have lots of queer couples I know that have children together. They often aren't using terms like mom and dad. They're using other ways to describe themselves as parents. But yeah, it's a fair. I don't think it's necessarily. Thanks for asking that in a kind way. But yeah, you can definitely still have dysphoria or be like not wanting to be a woman and still want to be pregnant, even though you identify as a trans man. It's definitely possible. Yeah. Yeah. Can you? Oh, perfect. Okay. I'm going to put this on to end this. Share. Okay. If you already have a GP and I ask them to give me gender confirming care, can they say no? Or are they ethically obliged to provide if a patient asks? That's a really great question. So technically your provider could be like, oh, I'm not comfortable with that, or I don't know enough about that. They do have that right, but they don't have the right to not then refer you to someone who does. So just because a provider is like, oh, sorry, it's just not on my wheel, or sorry, I don't like to do that, or I have um I don't know, a moral like distress about doing that, which screw any provider that says that, because that's absolutely inappropriate and trans care is a part of becoming a doctor. So like I don't know why people anyways, but for people, doctors who say that, no, so they could be like, sorry, don't know how to do it. And you'd be like, okay, great. So then you, in order to keep your license, need to refer me to someone that will provide me that care. Same for abortions. If you wanted a procedure, and someone can have moral distress about it, but they have to send you to someone. And if they don't, report them to the college, who can then follow up and help get you referred to where you need to. Okay, is dosage based off of weight? So for testosterone, no. And same with for estrogen, no. You might notice that you might not get the intended effects that you want, like the sex changes based on a certain dose. And sometimes people who have larger adipose tissue or more fat tissue might need higher doses, but that's not necessarily the case. So it's usually not based off of weight. There's usually like a typical starting dose for both estrogen and testosterone, and you go until you have the effects that you want. I don't even really look at people's like testosterone or estrogen levels. Some people are like, I need to be at this level, otherwise I'm not a man. But technically there's such a range for what's normal. So the only reason I care about people's blood levels of testosterone and estrogen is because I want to know if we've gone too far. Right. And oftentimes when you get blood work, like when you look at life labs and say you're a trans man and your testosterone and it says like 55 or something, it's going to be in red because unfortunately Life Labs is assuming that you, based off of female chemistry, that that's too high for a female, even though that would be considered normal range for a male. So just so you know, if you look at Life Labs stuff and you're like, why is this red? It's like, no, it's just because Life Labs sucks and didn't change, like didn't actually account for trans people. So that is why. Okay. Gosh, this information extremely helpful. Helping my clients navigate gender affirming care systems and knowing how much is covered by NAHB and Northern Travel Grants. Tremendously helpful. Your use of language comes across as intentional, inclusive, and inviting for individuals. Engage with us on many levels. Thank you so much. Aw, thank you. Can you talk about the accessibility of gender affirming care in First Nations communities? Very low. Very low. Accessibility, nil. No, I'm sorry, I shouldn't say that. That's not true. There are people who work on reserve, like for example, my colleague James McCocus, who provides gender affirming care on reserve in his own community. And he himself is, a part of that community. So, but I think it is limited. One, because all healthcare access is limited on reserve. Like I know this, having grown up on reserve. I think we had access to a nurse practitioner like twice a month for a population of 800 or 1,000, which is just absurd. So unfortunately, the accessibility is like just terrible. And that really needs to change. The ways that like myself as an Indigenous physician is trying to change that is by offering that care on reserve, but we also need people working on reserve. And in order to facilitate that, we need Indigenous care providers who are from those communities going to med school, not going through it and being super traumatized and then no longer wanting to be in medicine because medicine is racist and exclusionary. And then that community being ready enough for their own community member who's now a doctor to provide service. That's often a critique that you won't hear a lot of in mainstream media. It's just that a lot of Native doctors who are from their communities that try to go back to their communities, in theory, that seems like people want that. They hear that idea and they're like, that's great. In reality, a lot of Indigenous physicians who go back to their community are treated worse than a non-Indigenous physician. So there's definitely like some concerns around that, but that's the way moving forward. I think is our communities getting ready to have our own community taking care of us and treating our Indigenous providers well and getting people through medicine, surviving the process enough to want to continue to be a doctor. Okay, can I refer clients on reserve to ONWA to access care? Yeah, it's a great question. So ONWA is intended for people that are living in urban environments because there isn't like a health access center in the same way where it would be localized on reserve, where you're like, this is the health building, this is where we go. So this is it. ONWA's, I find most of ONWA's program is intended for people who are in urban settings because people don't necessarily have that. But what I would suggest is that you call our central intake line because anyone can access these services. Would these services be, for example, there was a service that could potentially be offered on reserve, but it is offered here in town. Would NIHB cover the travel for you to get from point A to point B in order to access their services? That I don't know, but if you call our central intake line and like depending on what that person needs, whether it's like healthcare, it's culture, they kind of help direct and figure that out. Yeah, so but definitely you can refer. Well, there's not really like you as a provider need to refer to us. The patient can just call like at any point in time and we will direct them and if we don't know the thing, we will find the thing. I think our team is really great at doing that. Okay, did I answer everyone's questions? think I answered. Am I missing anything, CJ? Okay, just send it to me. Yeah.
Or no.
Okay. Okay. Is working on gender affirming care in Alberta, but how many practitioners are available in Ontario for First Nation communities? Oh, she had mentioned that Dr. McCocus is working on gender affirming care in Alberta. How many practitioners are available in Ontario for First Nations communities? Great question. It's a very complicated answer. Okay, so because gender affirming care is not taught to the same extent as you would be learning about someone's birth control or like their blood pressure. Theoretically, general practitioners, nurse practitioners, doctors can say that they don't know how to do that. And so then not have availability. So there really isn't a way to know which doctors do it and which ones don't. Rainbow Health does have a directory of like clinics that like that's a part of what they do, but searching provider, like if you were to go to the Ontario, like the College of Physicians of Ontario and try and look at the different doctors that are in Ontario, you wouldn't be able to find the ones that offer trans care. So it's a bit of like a mismatch of like you have to call, you kind of have to know. If you yourself were like needing recommendations, then I would call the centralized intake line so that they could then direct that question. I could figure out where you are and then help you find someone. But Rainbow Health Ontario is a really common place that people go. And I think there is, it's not provider specific, it's clinic specific. Like, this clinic generally provides this type of care. That's usually the way people go about it. But other Native doctors who are providing gender affirming care to other Native people, yeah, that population gets a lot significantly smaller. I know James and I do it. I don't know. I really, not a lot. It's like a really small population of people. But we're trying to increase it, if that makes sense, through education. But yeah, Native doctors. So, because just having doctors, period, knowledgeable about this in order to provide care is difficult. And if you think of it, Indigenous physicians like make up 0.5% of the population of doctors, right? Even though Canada is made up of 3% of Indigenous people. So ideally, the amount of doctors you have in regards to an ethnicity should match, right? Based off of the population level. So Canada is made up of 3% of Indigenous people. Healthcare should be reflecting 3% of that amount, if not more. But we don't even have a lot of Native doctors to begin with. So hard question. And it really great pointing out of the gaps that exist. I appreciate that, but I'm not sure. It smells like systemic racism. Yes, you are correct. That is what that is. Correct. Okay. Anything else? Oh yeah, survey reminder. Here you go.
Okay, just for the few that are left of you that are left with us, just a reminder that our team posted the link to the survey in the chat. If you could fill that out, if you're able, anyone who fills it out will be entered into a draw for a prize that is relevant to this topic. Not going to say specifically what's in the prize because I'm not entirely sure, but we are
hoping it's a binder and a book.
Yeah, hoping that it's a binder and a book by a Two-Spirit elder in our community that is very special to us. So if you are able to fill out that survey, that'd be awesome. We really appreciate when you do the surveys and you offer us any sort of feedback, whether it be things that you would like to see or things that you enjoyed. All feedback is very much appreciated. So
when's our next one? I'm not sure. Do you
Do you
know
know?
what our next talk is?
Ah.
I'm sorry.
It's 4 to 5.
September 4th, our next Indigenous Women's Health Talk series is September 4th, 2 to 5. What am I talking about?
Traditional medicines, building our bundles with knowledge keepers.
Did everyone hear that? Okay. Apparently that's what I'm talking about in September.
I think this one's 2 to 5, so it's a little bit longer with an activity.
Oh, because we're doing a craft. Yeah. So
Yes.
if you register, then you will get the craft stuff mailed to you so that during the event we'll be going through the craft while you listen to my wonderful voice.
Yes.
Okay. Awesome. Miigwech, everyone. Thank you.